It's hard to change. It's such a big part of our current economy. It takes a lot to get people to change, and it's difficult to get them to understand why, because that's how they're getting paid. And so when we go out and talk to docs, we're having a big conference a summit next month to tell docs, how you're going to get paid is probably going to change. Let's come talk about it. Let's deal with the reality. It's our new reality. We've got to start talking about this because it's going to change. Other elements of the economy are going to force this on you. It is not PPACA, the bill that was passed last year. It's the economy that's going to be the major driving force of how you get paid in the future. And many people have been putting too much emphasis on the bill, when in reality the major driver has been the economy. If you want to sit down and write your own health reform bill, this is a good place to start. You want to improve the individual experience of the patient. You want to certainly improve the health of the whole population, something we have not been emphasizing in America. And the other one that we are afraid to talk about is reducing the per capita costs of populations. And that last one is one that we failed in the health care bill. We did not put cost control in the bill. We put things in the bill could lead to cost control, but we were wishy-washy about how we really were going to control those costs. And things that were in the bill, starting in the summer, that did control costs were taken out of the bill. Things like end-of-life care discussions because they were called death panels. That's where we spend most of the Medicare dollars, is in the last 2 years of life. We have to talk about end-of-life care, and we have to do it intelligently. That's a must. And the other one is using good science to determine where public dollars should be spent in health care. That's using comparative effectiveness and value-based purchasing. Some of the teeth using comparative effectiveness were pulled out of the bill because it was called rationing. And I would argue that if you're using good science to determine where you want to spend your public dollars in health care, that's not rationing, that's just being smart, using good science to determine where your dollars should be spent. So essential elements of the 21st century is going to change. It's not going to be volume-based, it's not going to be quantity-based. How much you do is going to be how much you get paid. It's going to be how well you do this. And that's how we restructure our health systems. Effectively communicate and coordinate, demonstrate continuous improvement, establish standards and monitor performance, and provide value to your community. Grand Junction has tried to do that, but it's interesting, the system that we've set up, the savings that Grand Junction has squeezed and given back into the big pot, the big Medicare pot, and the big Medicaid pot, we don't get to share that at the local level. That goes back, and everybody in the United States shares in the savings that was generated in Grand Junction, Colorado. So the folks out in Grand Junction, they're saying, why are you guys getting so much attention? Well, they're right. We haven't been able to share that savings with them yet because of the way our system is set up. The health care bill could change that. And unless you have a good understanding of this element, it's hard to go anywhere else with health care reform. I'll ask folks, do you think somebody with a pre-existing health care problem should be able to buy insurance in America? And most of the time, a good majority, not everybody, but a significant high majority, over 75%, usually raise their hands and say, yes, somebody with a pre-existing condition should be able to buy health insurance in the United States. Okay. Right now, it's hard to do that with the way the system's set up prior to the health care bill passing. There are only a couple ways you can ensure that somebody with a pre-existing condition can buy insurance in the United States. You could make a public option, and the public option run by the government won't turn anybody away. Well, we scrapped that idea, didn't we? Okay? So the compromise was, let's keep the private insurance companies, but here's the problem. The insurance companies can't afford, even if they decided they didn't want any profits, they could not afford to insure everybody unless we increased the pool of people insured. Okay? So you can't provide health insurance to everybody using private insurance companies unless you increase the number of people that are insured by a huge margin. So you have to require that people buy insurance if you're going to use private companies to get pre-existing conditions covered. That concept right there is still not understood, or if it is understood, it's denied by some people in the healthcare debate forum. I heard just the other night a representative in the Fed saying, we want the free market to solve the pre-existing medical problem. Well, we've been there, done that. We've tried that. The free market doesn't want to have anything to do with pre-existing conditions. That's how they make money, is to avoid the risky populations. They sit in rooms determining how can we reduce our risk. They don't sit in rooms saying how do we increase our risk. That's the whole idea of shareholder-driven insurance companies. Reduce risk, deliver health care to the folks, usually trying to maintain the healthiest folks to insure. They don't want to take on the unhealthy folks. It's not good for business. It's not the business model. So you've got two options, again, to cover pre-existing conditions. Public option or the individual mandate using private companies. Now, some people will say, well, Doc, you could create a risk pool, a huge risk pool. Well, that risk pool would have to be financed by the taxpayer. So essentially, you're creating a different version of a public option. So if you understand that element right there, you understand the foundation of the rest of the bill as it comes out of an individual mandate and the tax structures that you need to allow people at or slightly above up to the 200, 300% of poverty level to purchase insurance. Because if you're going to tell them you have to buy insurance, you're going to have to provide the subsidy to buy it. We've identified some major problems with the bill. We talked about some of the things that the Medical Society, Club 20 have agreed upon, the individual mandate. The 208 Commission agreed upon the individual mandate. Voters of the state of Colorado voted to not overturn the individual mandate in the state of Colorado. But, we talked about cost control. It's not enough in the bill. The sustainable growth rate, how the government pays doctors, did not get fixed. We really haven't addressed the liability issue in the bill. It's a little bit in there for it, not enough. And from a physician standpoint, there's a big movement on coding, but suffice it to say they're doing that because of the amount of fraud. So we're having to deal with that. And of course, the IPAB, which is this committee that if we don't get cost savings out of this in a few years, this small group of people that will be telling us how we're going to save money in healthcare if we don't start seeing the cost savings. And how that committee is set up is going to be extraordinarily important. It's very controversial. But that committee is going to start making big decisions in 2014 or 2015 if they don't start seeing the cost curve bend a little bit. It doesn't have to go down. We just have to bend it down a little bit from not going up as fast. Let's get back to Grand Junction. We started off with that little vignette about doctors just getting together and starting to have a conversation. The idea was improve access for a certain population, improve reimbursement for the docs so that they would see those folks. Out of that grew Rocky Mountain HMO. And working with the physicians of Mesa County, the IPA, they started working together on creating that relationship to move forward. But there was always an idea about quality, and there was always an idea in the end that we have to control cost. And so through the years, we graded ourselves, the docs, on cost, and we graded ourselves on quality. And doctors that were seen as high cost, report cards came out, and we all saw those numbers. We were monitoring it. We were watching it over time. And so there was about some peer pressure on keeping costs lower. And that started way back in the 1980s as the IPA, the Independent Physicians Association, was working with Rocky Mountain Health Plans to control the costs to keep this a functional system. The other thing that they decided to do was for Medicare and Medicaid, we'd increase the reimbursement to the doctors so the doctors would see the patient. And the doctors agreed to get paid less through the commercial Rocky Mountain Health Plan system, to funnel money over to the docs that were seeing more Medicare and Medicaid. Can you imagine that? Doctors saying, we'll give up, we'll see less, we'll get less money for our commercial paying patients so that the docs that are seeing a lot of Medicare and Medicaid get paid more. That's an idea that is about the community. That's not just about me. That's about serving the community and making it functional for the community. You work together, you collaborate, and you cooperate to make the system more functional. So here's the players over in Mesa County that have made that happen. The IPA, of course, Rocky Mountain Health Plans. It would not have happened without a nonprofit health insurance company that wanted to be part of this. St. Mary's Hospital, which is a nonprofit, Community Hospital, which is a nonprofit, Quality Health Network, which grew out of the IPA, and primarily Rocky Mountain with some seed money as well from the hospitals. But that's our information exchange that's now getting huge grants from the feds because it's done so much. It's now a beacon. It's one of the beacon communities that's sharing that idea and moving it outwards on the western slope. Marillac Clinic, that's our underserved clinic that's not an FQHC. Hospice, Hilltop, Home Care of the Grand Valley, the Health Department, and of course Colorado West Mental Health. There is a theme there, and there's a lot of nonprofits there. You know, the docs aren't nonprofit. That's how we get paid salary. So you know, there's elements there that are for profit, but it certainly did help. So what are the numbers? Ann referred to this earlier, and we got highlighted in the New Yorker about 2 years ago now by Atul Gawande, and showed the difference between Grand Junction and McAllen, Texas. Now the demographics are a little bit different from one town to the next. It wasn't a totally fair article, but we could put up other, you know, Southern Florida, Southern California, where the numbers on per Medicare beneficiary price tag are even higher than that $14,000 mark. And Grand Junction's not all that healthy. We've got as high a diabetic or higher than the rest of the state of Colorado. It's not this, you know, land of just 20-something and 30-somethings. There's a huge, significant Medicare population there, big retiree population, and plenty of sick people. So it's not like this is an ocean of health over in Grand Junction. Why is it happening? Because we were willing to address hospital stays, the lengths of stay, incentivize shorter stays. We incentivize transitions of care, good communication from leaving the hospital and going out. I, as a doctor, get paid, even if I'm not doing anything for a Rocky Mountain Health Plan patient, to go and oversee the work that's being done by a specialist. They'll pay me to go into the hospital and say hi to the patient, see what's going on, visit with them, even if I'm not doing anything. Writing orders are an integral part of it. They want me to be a good transition person from that person leaving the hospital going out so that person doesn't bounce back into the hospital. We have the lowest rate of transition of care, of bounce backs, readmission rates in the state of Colorado. In fact, Senator Bennett modeled